Next, we are going to discuss acute respiratory distress syndrome, or ARDS, and ventilator management. Yay! I know y'all are excited for this one. Here are your objectives related to ARDS and ventilator management.
ARDS is a life-threatening condition with a very high mortality, and it has a rapid onset, making it difficult to detect often in the early stages. And the treatment for ARDS can be especially challenging because it's often limited to supportive care, especially when we don't know the underlying cause. ARDS is an acute and diffuse inflammatory lung injury. So basically, it is that surge of the lungs. And it's going to be characterized by refractory hypoxemia, and the lungs are going to become stiff and non-compliant because there's going to be widespread alveolar damage. ARDS is going to be characterized by significant injury to the alveolar capillary membranes where gas exchange occurs. And this injury is often going to be direct, like in cases of aspiration. However, it can be caused by that secondary inflammatory response, like seen in sepsis. What's going to happen is injury is going to occur, or the systemic inflammatory response is going to initiate, and it is going to release those pro-inflammatory markers that are going to increase that capillary membrane and cause fluid to leak out into the interstitial space of the lung, ultimately preventing gas exchange and leading to alveolar collapse. And this is usually going to occur about 1 to 2 days after that pulmonary insult. Think about it. Inflammation takes time. ARDS is going to be divided into 3 phases. The first phase is the exudative phase, and that is where you're going to have that initial diffuse inflammatory response where you have that release of those pro-inflammatory markers and the increased capillary permeability and the leakage into the interstitial space of the lungs. And that's when the patient's going to experience significant hypoxia, and they may require mechanical ventilation at this time. Now, the patient is going to progress into the proliferative phase. That's where you're going to have all the fibroblasts and whatnot attempting to repair the lung tissue. And most patients are actually going to recover in this phase. However, depending on the extent of that damage that occurred in the exudative phase, if it was significant, patients may end up in the fibrotic stage, and that is where the lung tissue is going to begin remodeling. The lung is no longer going to be compliant. It is basically going to stiffen up like a rock, and ultimately death is usually going to occur. Risk factors for ARDS can include conditions that cause direct injury to the lungs, such as pneumonia, aspiration, inhalation injury, those who have had near drowning. And ARDS can be caused by those indirect causes that are going to cause a systemic inflammatory response, such as your burn, sepsis, drug overdose, pancreatitis. And this is going to be where our trolley can come in and cause ARDS. Clinical manifestations of ARDS are going to include those nonspecific signs of hypoxemia, such as tachypnea, increased work of breathing, dyspnea. However, in order to make a differential diagnosis of ARDS, all of the following criteria must be met. The patient must have an acute source of injury or inflammation. The patient must have bilateral diffuse infiltrates, aka pulmonary edema, on the chest x-ray, and it cannot be cardiogenic in nature. For example, if a patient's having a heart failure exacerbation that's causing the x-ray to look like that, you cannot diagnose them with ARDS. The patient must be having refractory hypoxemia despite the delivery of high concentrations of oxygen. And their PF ratio has to be 300 or less. And your PF ratio is just a measurement that compares the amount of oxygen in the arterial blood to the concentration of oxygen being delivered to the patient. For example, you and I are breathing 21% oxygen. And you would expect our PaO2s to be anywhere from 80 to 100. So just imagine these patients that are on 100% oxygen and their PaO2 is only in the 80s. And your PF ratio is just going to help us determine how severe your hypoxemia is and if your clinical condition is worsening. Diagnostics for ARDS can include ABGs, chest x-rays, CTs. We are going to do various tests to try to find the causative factors, such as blood cultures, sputum cultures. Depending on the underlying cause, ARDS treatment is often limited to supportive care. You may have heard of proning. When a patient has ARDS, they are going to have a ventilation to perfusion mismatch or a VQ mismatch. And when a patient is supine, the weight of their organs can compress the lungs, which can lead to poor gas exchange in certain areas. And proning has been shown to increase perfusion to areas of the lung that were poorly oxygenated, allowing for that gas exchange to occur on the capillary membrane. So proning is going to be one of our primary interventions. And we know that patients with ARDS are going to have very poor lung compliance. And a lot of times when they are receiving mechanical ventilation, they are going to start fighting the ventilator. They're going to initiate breaths against the ventilator. They're going to peak pressure if they're on a volume control mode, or they're going to have issues with their volumes if they're on pressure control. And when this happens, we are often going to begin paralytics. So we are going to chemically paralyze the patient. It's important to note that in order to paralyze a patient, first of all, they must be on a ventilator. And second of all, you must always sedate them and ensure that they have adequate sedation before you begin the paralytic. And protection, you want to try to use low tidal volumes to protect the lungs. These patients are also going to need supportive care to maintain their cardiac output, their renal function, their acid base. If there is a suspected infection, that's when you administer antibiotics, but you're not going to give prophylactic antibiotics in most cases. You want to make sure that you are maintaining their nutritional and fluid balance. A lot of times these patients are going to need diuretics. You want to make sure that you have that GI and that DVT prophylaxis going to prevent ventilator-associated events. Medications can include antibiotics if there's a suspected infection. Pulmonary vasodilators like your inhaled nitric oxide. What this is going to do is it's going to dilate the pulmonary vasculature, allowing for more air intake. You may see things such as surfactant, corticosteroids to try to stop that inflammatory or that immune response. You're going to have those neuromuscular blocking agents, sedatives like midazolam, propofol. This chart is going to show you the primary causes of ARDS in different patient populations. As you can see with the pediatric patients, most of the time ARDS is going to be associated with things such as near drowning, pneumonia, trauma. With our pregnant women, most of the most frequent causes are going to be associated with pregnancy, such as preeclampsia, amniotic fluid embolus, postpartum hemorrhage. And with our older adults, we're going to see that the primary cause is going to be pneumonia. You will also see some different treatment variations amongst the different patient populations. With patients with ARDS, in our pediatric patients, we're generally going to allow permissive hypercapnia. So we're going to allow higher levels of CO2 to help reduce the risk of a ventilator-induced lung injury. And you'll see that we don't prone children. We're generally going to avoid steroids. And with pregnant women, we need to take into consideration that there's 2 patients there. And with our older patients, we generally want to think about how their advanced age and comorbidities may impact their survival and quality of life. Next, I'm going to talk to you a little bit about mechanical ventilation and ventilator settings. Often when patients present with ARDS, they are going to have such poor lung compliance that supplemental oxygen on its own is not going to be enough to allow for adequate gas exchange. They're going to need additional pressure to prevent that alveolar collapse. So often these patients are going to require mechanical ventilation. Now, there are 2 different modes of mechanical ventilation. There's the non-invasive positive pressure, which is going to be your CPAPs and your BiPAPs. But CPAP is specifically for sleep apnea, and we don't use it in the clinical setting to treat respiratory failure. Instead, we're going to use BiPAP. And BiPAP is going to help keep the alveoli open by applying different pressures between inspiration and expiration. But often when patients have that ARDS, they are going to require invasive positive pressure ventilation, and they are going to need to be intubated. And just to reiterate that information from Module 1, invasive mechanical ventilation is going to be achieved through the insertion of a tube, usually through the patient's mouth or nose, and it is going to extend into the trachea. That is intubation. And the endotracheal tube is going to be connected to a ventilator circuit, which is going to allow us to deliver air and oxygen directly into the patient's lungs. And when a patient is experiencing respiratory failure or poor airway compliance, like with ARDS, One of the benefits of this mechanical ventilation is that it's going to allow us to manipulate certain variables, such as the patient's carbon dioxide levels through the respiratory rate and how much oxygen they are receiving. And this can allow for better ventilation, respiration, and ultimately oxygenation. There are various ventilator settings and modes that can be manipulated to help a patient achieve optimal oxygenation. These modes and settings are going to be ordered by the provider, and they're going to vary and be dependent on the patient's individual needs. Components of ventilation can include tidal volume, which can be set or variable, and pressure, which is the force the ventilator uses to deliver that breath. This can also be set or variable, and the rate can also be set, or it can allow patients to breathe spontaneously, or it can use a combination of assisted and spontaneous breathing. Now I'm going to talk to you a little bit about ventilator settings and modes. We discussed this in lab, and I'm not going to test you on this, but basic ventilator settings and modes can be on your NCLEX, so I would like to just go over them with you and make sure that you're comfortable. Your FiO2, that's just your fraction of inspired oxygen. You and I are breathing 21% unless you have a nasal cannula in while you're listening. And sometimes when a patient is on a ventilator, it's due to airway issues, or they just need a little bit of additional pressure. They may not have any additional oxygen requirements, so it is possible to be on 21% oxygen on a ventilator. However, usually when a condition is going to warrant mechanical ventilation, a patient is going to have additional oxygen requirements. We usually titrate the FiO2 based on a patient's ABGs. Sometimes you'll see the provider use their SpO2. Respiratory rate. This is just going to be the frequency of breaths delivered. Standard is going to be 12 to 20 a minute, but there's going to be many conditions that may warrant a higher respiratory rate, like ARDS, or we may go outside of those parameters based on a patient's ABGs. We may look at their acid-base balance. For example, if a patient has metabolic acidosis, we may increase that respiratory rate. I've seen it in the 30s in this situation quite frequently. And we do that so that the patient can blow off that extra CO2 and help normalize their pH. Tidal volume, that's just the volume of air being delivered during inhalation. And PEEP, we all have PEEP. It's called physiological PEEP. And this is just pressure in our airway to prevent our alveoli from collapsing when we breathe out. Patients who are on mechanical ventilation are often going to require additional PEEP because they are experiencing conditions like respiratory failure, poor airway compliance. And PEEP is like a double-edged sword. It is going to allow for better oxygenation, but at higher levels, it can actually induce barotrauma. Think about it. When we are on high doses of PEEP, that pressure is just going to build up in those alveoli, and eventually they're going to rupture. And this can lead to things such as additional atelectasis, subcutaneous emphysema. Next, I'm going to talk to you a little bit about the most basic modes of mechanical ventilation. We have our assist control mode, and with assist control, the tidal volume and the rate are going to be set. However, the patient can still initiate spontaneous breaths. But when they do, the ventilator is going to deliver a set tidal volume to ensure that they're getting adequate volume. Now, Volume control versus pressure control. At any given time, we can only manipulate one of these variables. We can only manipulate the tidal volume or the amount of pressure to achieve that tidal volume. Volume control is generally going to be our standard mode of ventilation. And with volume control, we set the tidal volume, but the amount of pressure it requires to deliver that volume is going to be dependent on the patient's lung compliance. And in certain situations, it's going to require a high amount of pressure to achieve that volume, and this can lead to barotrauma. Pressure control is generally going to be reserved for patients with refractory hypoxemia because with pressure control, there is a high risk for volume trauma. And volume trauma is the same basis as barotrauma. The only difference is with volume trauma, it's just volume or air that is causing the alveoli to hyperinflate and rupture. And one of the downfalls of pressure control is we cannot control the patient's tidal volumes. They may be taking too little tidal volume in, and that's when they're not going to oxygenate, or their tidal volumes can be too high, and that's where the barotrauma comes in. Next, I'm going to talk to you about SIMV. And SIMV is going to combine both mandatory breaths delivered by the ventilator and patient-triggered breaths. And we don't use this mode of mechanical ventilation often in the acute critical care period. But in patients who are extremely difficult to wean and require long-term ventilation, you will see this mode used. You will also see this mode used in patients who are going to require that long-term airway and mechanical ventilation because they have severe muscle weakness from diseases such as Guillain-Barré, ALS, because this mode of ventilation is going to provide partial ventilator support, but it's going to allow the patient to maintain some degree of spontaneous breathing. In the acute care, critical care setting, we usually use our pressure support CPAP mode for weaning. And CPAP mode is going to allow the patient to initiate all of their breaths, but during those breaths, the ventilator is going to deliver a set amount of pressure to help them. And this is a great mode for weaning, especially for patients who have only required short-term ventilation. Now, anytime we introduce something new to the body, it is going to come with certain risks. One of the major risks of mechanical ventilation is going to be ventilator-associated pneumonia. Now, a ventilator circuit is a closed circuit. However, often critically ill patients are going to be at risk for opportunistic infections, or they may have certain colonizations of bacteria on them that are generally not infectious. Like, for example, a lot of people have MRSA and it's non-infectious. Well, now when we place them on mechanical ventilation, we can introduce that MRSA into the lower respiratory tract, causing pneumonia. Often when a patient on mechanical ventilation spikes a new fever, or we see new infiltrates appear on their x-ray, or they show clinical signs of infection, we suspect that the ventilator has now become a reservoir for that infection. So you'll usually see respiratory cultures, blood cultures will be ordered, and you will start them on broad spectrum antibiotics until you find out the exact pathogen that is causing it. A lot of times it's going to be like a staphylococcus, sometimes it's MRSA, but then we will find an antibiotic more specific to treat that organism. Barotrauma can also result from mechanical ventilation, and that is just going to be over distension of the alveoli. And a lot of times, when we have the patient on high PEEP, we're going to cause so much pressure in the alveoli that they're going to rupture, causing air to leak into the interstitial spaces. This can lead to subcutaneous emphysema, a pneumothorax, and other additional complications. When a patient is on mechanical ventilation, that's going to alter their cardiorespiratory function, and this can lead to decreases in cardiac output, changes in interthoracic pressure, which can bring about additional complications. And now we have to also think about the GI risk, which, such as when a patient is on mechanical ventilation, this can contribute to stress ulcers, which can contribute to reflux. And if there is a leak in your cuff, if you're vomiting, it'll go right up from your GI tract, from your esophagus, right down into your respiratory system, leading to aspiration pneumonia. So again, there's many risks associated with mechanical ventilation, and that is why we are very, very meticulous in trying to wean ventilator so we do not continue to pose these risks to patients. Nursing interventions include oral care, which is generally done every 4 hours. And every 12 hours, we're going to use a toothbrush device and a subglottic suctioning tool. Secretion management. Generally, we don't routinely suction the endotracheal tube because that can lead to airway trauma, but as needed. But frequent oral suction is important. And remember, when we are suctioning that ET tube, you want to pre-oxygenate the patient with 100% for 2 minutes. You want to make sure that you do not suction greater than 10 seconds and that you are watching the patient to make sure they're tolerating it. You want to always keep the head of the bed at 30 degrees or higher. You want to do frequent turning. And remember, proning can be very beneficial to the ARDS patients. You want to monitor for signs of barotrauma, such as subcutaneous emphysema. And you want to address and report all ventilator alarms. And when a patient is requiring high PEEP, you want to monitor closely for signs of decreased cardiac output because that is going to change the intrathoracic pressure. And you want to ensure that all patients on ventilator support have either a PPI or an H2 blocker ordered for stress ulcer prophylaxis. And you want to ensure that their nutritional needs are being addressed. Likely these patients will have an NG tube or an OG tube, and we are going to feed them through the gut. But sometimes certain conditions may require TPN. And always you want to make sure that you have a ambu bag at the bedside and a Yonker suction device. Next, I'm going to talk to you a little bit about ventilator-associated pneumonia and your VAT prevention. Ventilator-associated pneumonia can be fatal, especially for patients who are already experiencing life-threatening conditions, such as ARDS. And your VAT bundle is just a set of clinical interventions that are going to be designed to help lower the incidence of ventilator-associated pneumonia. The first one is keeping the head of the bed elevated from 30 to 45 degrees to prevent aspiration. Next is going to be Q4 oral care with chlorhexidine being used twice a day. But a lot of facilities are getting away from the twice a day chlorhexidine as long as you are still using a toothbrush every 12 hours and that subglottic suctioning tool. Next is going to be your stress ulcer prophylaxis. That's where you're going to have that H2 blocker or that PPI to prevent those stress ulcers, because ultimately this can lead to gastrointestinal bleeding. It can lead to increased incidences of aspiration. Next is going to be our DVT prophylaxis. For patients in the hospital, you will often see Lovenox used. Sometimes in critical care, you will have patients that are suffering from chronic renal issues mixed with a combination of acute renal issues. And if the creatinine clearance is less than 30, we are going to use subcutaneous heparin. But I'll talk more about that when I get into renal impairment in Module 4. Also, daily sedation assessments. This is where on patients that can tolerate it, we are going to wean their sedation and do spontaneous breathing trials to try to wake the patient up, see how well they are breathing, to try to remove them from the ventilator. Because ventilator-associated pneumonia is going to increase the amount of time a patient is spent on the ventilator. It's going to increase hospitalization days. It's going to increase cost, morbidity, and mortality. And so it is essential that we are using these evidence-based approaches to help deter it. Next, I'm going to talk to you a little bit about ventilator alarms. Yes, respiratory manages the ventilator, but A, you should always know what's going on with your patient's condition, and B, sometimes your ventilator alarm is alarming because of something that is going to be nursing focused. For example, when my patient is agitated, they're biting down on their tube, they are thrashing around in the bed, my high pressure alarm is going to alarm. And there's not a thing in the world that respiratory can do to help me. This is a sedation issue. Let's start with our low pressure alarms. These are going to be caused when not enough pressure is in that circuit. It can be caused by a leak, a loose connection, the patient has self-extubated, the tube has become dislodged because of forceful coughing from moving the patient and not stabilizing the tube. There's various reasons, but I want you to think something is loose or not connected, or there's a leak. Then you have your high pressure alarms, which are much more common and a nurse's worst nightmare. They're going to be caused by things such as pulmonary edema, a pneumo, a bronchospasm, and more commonly by patients biting on their ET tube, coughing, gagging. It can be caused by secretions causing an obstruction or a kink in the tubing. And when your patient is going to be on the weaning modes, like your CPAP mode, you may hear your apnea alarm. And the apnea alarm is going to be triggered when this patient is not taking spontaneous breaths, or they are not taking the expected amount of spontaneous breaths. Next, I'm going to talk to you briefly about ABGs, just because many of you indicated that you were having difficulty correlating those ABG values to the patient's clinical status. Patients who are receiving mechanical ventilation will often receive serial ABGs because ABGs are going to give us an inside look at how well the patient is ventilating, how well gas exchange is occurring, and if they are eliminating carbon dioxide appropriately. And the ventilator settings and modes are going to be manipulated based on these values. When a patient's partial pressure of oxygen is low, that's when we'll increase the FiO2. But if their partial pressure of oxygen is high or normal, we can start titrating down on that FiO2. But another advantage of ABGs is it allows us to manipulate certain factors that are causing a disruption to a patient's acid-base balance. For example, if a patient has metabolic acidosis, then we can increase the patient's respiratory rate on the ventilator to blow off more carbon dioxide and to help normalize that pH and maintain homeostasis. All right, you can wake up now. The presentation is over.